Okay, everybody, we've made it. It is with a great deal of pleasure and some relief, I think, Leanne and I would like to welcome everyone to this closing ceremony for NI 2024. We hope that you've enjoyed your experience as much of the conference as we have, and throughout the last few days, we've heard so really exciting initiatives that are ongoing globally in the field of nursing informatics. And I know from some of the informal conversations I've had with people how much everybody has got out of the ability to talk to each other about our work. And it's just been wonderful. So we hope that our final two speakers will carry on that conversation and provide you with some thoughts and challenges for how we advance our field for the future. So I'm now going to hand over to Leanne.
Thank you so much. It gives me great pleasure to introduce our first keynote speaker for this morning, Dr. Charlene Ronquillo. Charlene is a Filipina scholar, registered nurse, health informatician, and the lead of the Health Informatics Equity Lab at the University of British Columbia. This is my university, can't say it. University of British Columbia, Okanagan School of Nursing. The goal of her work is to improve equity in healthcare with thoughtful and inclusive technologies. Dr. Ronquillo's ongoing research aims to ensure the meaningful inclusion of non-dominant groups in the conceptualization, design, development, and implementation of health technologies in health systems. Welcome, Dr. Ronquillo.
Can we swap, please? Thank you, everyone. What an absolute pleasure to be here today. A little bit shocked still that this immigrant kid from the Philippines has made it here. This is not just like for attention. Oh, sorry. This shirt thing is not just for attention. It's just representing my people. I'm sure we're all nurses. So you've all met your various country Filipino nurse posses. There's a lot of us all over, but not at this stage. And so very, very pleased to be able to represent here. So as was said, I'm talking about health equity and AI today, and focusing heavily on the equity end of things, and we're hoping to raise some questions about the things that we need to think about moving towards action rather than conversations, kind of getting stuck in these loops. So we've heard throughout these conferences, the sessions that I've attended around the promises that AI can bring to nursing, risk predictions to optimize care, allowing for earlier interventions, optimizing staffing care mix, chatbots to support information and knowledge seeking, for example. But among the many other things we've also learned in recent years is that these AI tools can hold biases, so this is not new. And these are holding up a mirror to us of what societal biases exist in a very tangible way. So this is a newer, I think this is the newest version of DALL-E I just generated a couple days ago. This is supposedly what nurses look like in various clinical settings. They all look like the same person with various hair, smiling and posing to the camera. So I've done this generation a couple of years back. Like, the quality of the image has gotten better, but the content is still very much the same. They're all female, etc. I changed the prompt to doctor, and you'll see mostly male. They're too busy to pose to the camera. They're very busy with their charts. Again, the blueness that was mentioned by some people. The future is blue, apparently. And just like very busy and much more important. So this is a mirror of how society sees us, because these data that inform these are scraped, from the public knowledge. So those are kind of, I guess, not really that fun examples, but kind of comical examples. But when in healthcare, we know that this comes out very much differently. This landmark paper by Obermeyer, I'm sure many of you are familiar with, they had kind of looked at, dissected kind of an audit of this algorithm that was used to manage the health of populations. So they're assigning risk scores and finding that risk scores assigned to sicker Black patients, they were getting assigned lower risk scores as compared to less sick white patients. And that was because of a very human choice of using cost of care as a proxy for severity of care. So this study was in the US, where the Black population uses more Medicare as compared to private insurance that's used by white populations. And so if you're equating cost to severity, this is what comes out. There's also work, and some of this work is being done by colleagues here, around identifying the ways that implicit biases of clinicians make their way into electronic health records. So stigmatizing language shows up, biased language shows up, and just raising the point of, if these are the data that we're using to fuel our algorithms or models, what does that mean for us? I always like to point out that these conversations around algorithmic bias are not new. These have been happening. Prolific work, extensive work has been done in other fields. And these are some of the books that have influenced a lot of my thinking that have been done in social sciences. So Cathy O'Neill's book especially, I really enjoyed, called The Weapons of Math Destruction. Talking about how the models we build in other fields, so criminal recidivism, so how likely it is that somebody released from prison will recommit a crime, for example, and there are many other examples in other fields, around, again, embedding these biases into these algorithms. I really, as I've thought about this more over time, I've come to kind of simplifying all of this thinking around algorithmic bias as issues of power. It's embedding power into the models that we're building. It's really a question of, this is the common thread across different areas of application of AI. So the power to decide what is the target goal, what is the task we want to accomplish. There's a person, there's a human, there's a group of people that are deciding that that is the important problem that we need to solve. The power to decide which features are included in the models and what feature engineering looks like. Again, those are explicit decisions made by individuals. The power to decide what labels to attach to those features. So there's some stuff around sentiment analysis and around, it's not really the sentiment we're detecting, but are somebody's understanding of what sentiment a word represents. So there's kind of this filtering that happening through the labeling process that is influenced by that particular person that is attaching the label to the data. And then the power to interpret those labels into particular ways of understanding, and then to make real-life decisions about those interpretations that ultimately will affect the health of individuals and populations. So when we talk about the problem of algorithmic biases and the problem of AI models producing inequitable outcomes, we are really talking about the ways that we're embedding existing societal norms, conventions, and values. And because we live in inequitable societies, it is really not that surprising that the models are biased. After all, the models rely on these retrospective data that have been shaped by histories, by contexts, societal and institutional structures that are in most places fundamentally inequitable. But I think what perhaps we weren't ready for was the ways that these inequities have been made so stark. The vision generation, for example, like we can see what people think of nurses or whoever it is. The algorithmic risk score producing outcomes that are different for different racial groups. It's made it very, very concrete and real. And now we have to contend with what that means for us in the context of healthcare. This is Cynthia Nixon's work. So anybody kind of who's worked or is interested in health equity will know that people and populations are treated differently because society has been purposefully built to privilege and uphold the privilege of some groups as compared to others. So it's not privilege or oppression or disadvantage is not something that it's unearned. It's because of what education your parents happen to have, the postcode that you happen to be born in. It has nothing to do with you, yet this shapes where you are in society and your starting point from where you're kind of beginning life. And so what I really like about this image is really pointing to the system, that's a coin in the middle, that is kind of dividing the groups into privileged and disadvantaged. And we tend to, in healthcare, only look at the disadvantaged side. We have this kind of savior complex of lifting people up from oppression, not recognizing that the underlying systems are actually what need dismantling. And then also, we tend to ignore the people who are experiencing privilege because that is what's normal to us. And not raising the question of what can that privilege do to help dismantle the coin as well. And so this is kind of what this looks like in action. Sorry, it's not rendering very well. But just some categories of identities there around typically, at least in Western society, who tends to be considered advantaged and disadvantaged. So a lot of the conversation around equity and bias has kind of crystallized around this discussions around fairness, at least in the context of AI. And this is a really nice paper by Liu et al. That kind of, they did a survey of how people conceptualize fairness in a computational sense. And this is part of the conclusion that they talk about, equity is an interesting direction because they may extend or contradict existing definitions of fairness. So we have this kind of idea, this normative idea that to make something fair, to make an algorithm fair is to make it work the same way for everybody. Yet equity talks about giving the things that are needed, like to match the needs of people. So it's not the same for everybody, but matching to the needs of folks. And I do think that's kind of the next step of the challenge in terms of ensuring actual fairness and not just kind of, reducing it to this idea of equal distribution. So I find this a useful framework, again, to point to power as the central thing to really pay attention to, at least this is how I orient my work, raising questions around whose needs are recognized, who or what is driving the quest for a solution, who is missing, what is missing, why are those people missing, who is controlling the resources, and who will be affected. And this is kind of repeated a lot in a lot of anti-racist work. It's impact that's important, not intent. Nobody intends to cause harm. Nobody, it's always like, well, I never meant for that to happen. That doesn't matter. And I know there's different views on this. That doesn't matter. It's the impact on the populations at the end that really matters. And that's, I think, what we need to kind of reconcile and work backwards from. So some of the challenges we are contending with, considering equity is not the norm, at least in a lot of healthcare AI work, not just nursing, but just general kind of medicine as well. Still really common, I see all the time proposals and papers that equity is not mentioned or considered, or done so in passing. There'll be kind of a throwaway line in the conclusion that says, and we should consider equity, like the end. So we're not really good at kind of embedding this still in our ways of thinking. And I also just want to acknowledge that this is not easy to do. This is uncomfortable to admit that, like, all of us are in this room because we are privileged to be here in one way or another. There are so many people, as have been mentioned in the beginning, who are not able to attend because of resources, difficult to get a visa, all of these things, right? Like, the passport that you have determines whether or not you can participate here. So just kind of pointing to that, and like, this work is uncomfortable if we want to do it in a genuine way. And so we know as nurses, we're social justice advocates, so we know that identity characteristics shape people's health opportunities and outcomes. Yet systems aren't designed, we aren't really trained to normalize this as a way of doing things. So this Progress Plus is just a framework that I've been using recently. So this is a result of a Cochrane review around kind of definitions and concepts of health equity and the things that you consider. So you can see all of these here. I think putting on our clinician lenses, these are obvious. Like these are things we need to think about if you're developing a care plan or discharging someone. Yet the infrastructure to support the collection of these data, let alone the use of them, are not there for most places. I can speak from Canada, but I feel like this is common. If someone's doing this, great, please tell me and let me know. Leading to health data poverty, right? So we know, I've heard from a few of the talks and the sessions around as people are exploring the data sets that they have, that there's documentation, more documentation for some groups over others. Whether or not those are systematic, what is the cause behind that, we don't know. But it's leading to this data poverty, as we know, is leading to algorithmic bias. But also in building these technologies, in one of the sessions we were at, we were talking about how a lot of the AI models are really going to be the most beneficial for the people who are, maybe outliers. But we remove the outliers when we're building models. And so what does that mean for the utility of these things? And are we not just in terms of the outcome of the prediction, like the application as well? Is that perpetuating bias? Does that mean some people can make use of these technologies as opposed to others? We know this is like old news. SDOH are not well represented in the literature as well. So this is a review we did a while back looking at SDOH representation in nursing and allied health data, and generally not really there. Part of kind of the normalization of not being part of the process. And this was an interesting study that looked at the training data sets that are used by machine learning studies, and you could see that there's a tendency to, a lot more of the studies use data sets from particular states, probably because they're cleaner, they're easier to access, et cetera. And we all know that data access is one of the, probably the biggest challenge. But the thing I want to raise here is, if the data that we're using are all coming from these cohorts, what does that mean for applicability to our particular contexts? I'm just looking at my time and I'm going to go faster now. And equity considerations across the pipeline as well. So ChatGPT, I've heard, everyone's talking about ChatGPT and the great things it could do. Not as many people talk about what made ChatGPT. And the short answer is exploitation, I'm sorry to say. Data labelers working in very, very low pay, like nothing paid, as you can see there. A lot of precariousness. This is what made ChatGPT and other LLMs, is exploitation in other countries. All we see is the shiny end of it. So I think being mindful as well about the tools that we are using and what it actually took, like the human cost of all of these things. Nurses are still not at the table much. We've been talking about this for like years and years and years. So this was a recent strike in California. And it's funny, they had like a clickbait headline, but you see that the demand was actually like nurses just want to be part of the process of deciding what AI is used for and how it's used. Yes, that's not really happening. And this was also true in all of the kind of AI papers. I scanned through them at this conference, is nurses need to be at the table, but we're still not. Okay, so another study just kind of to support that point, a systematic review done by Dawn and colleagues here around the extent to which nurses are involved in nursing AI studies. So the 30% mark is kind of encouraging, but then 48% still had no nurse involvement at all. But I'm a downer, so I was like trying to flip it to like positive things that we have control over. So these are the usual things we hear, right? Patient-centered care, like all of these lovely things, ethical AI development, transparency, explainability. I won't repeat this as like preaching to the crowd. I really want to reorient to this idea of looking to power, interrogating power across the AI data development pipeline, from identifying our data sources and integrating the data all the way through to implementation. And just asking these questions I've found have been really helpful. You know, like, for example, at the stage of identifying the data, what do we know about who are and aren't well represented in the data sets? What do we know about the ways that social determinants are considered or not? As we identify the data gaps, can we consider ways of advocating for filling those data gaps, et cetera? This is really necessary, like working on making data sets better, like the least sexy, least fundable part of AI, is what we need, I think, to also do in conjunction. So, you know, I heard from many studies that, like, yeah, like just the misrepresentation or the poor representation, like maybe it's time to reconsider our conventions around documentation and why we're doing documentation, and leveraging these technologies to help us do these things better. This was also part of the conclusion in the Obermeyer study. So they actually had the opportunity there to work with the manufacturer of the algorithm to correct. And it was like, the solution was changing a data label, if you can believe it or not. And so again, focusing on kind of the fundamental influence of those decisions, those human decisions around how you're setting up the data, is crucial. This is a very recent study. It was like 2 days ago. They analyzed the use of open data versus closed data. So, and they found that the use of open data, or the availability of open data, was really helpful in, you know, improving diversity and inclusion as part of the team, which I think is also a crucial step in embedding equity better. So in their analysis, they saw that authors from low and middle income countries and minority serving institutions, there were more authors on papers that used open data as opposed to closed data. So this is something to think about as well, as I rush through the last 30 seconds. Okay, so I think one of the things, and for those who have heard me in other sessions I was talking about, I think we still need to do a better job of building the evidence for what is nursing, and like stop arguing about what is nursing. It's like, take your definition, link it to outcomes, and then let's put that together. Maybe that's a way forward rather than going round and round and round. But the evidence isn't there for why this is valuable for clinicians or health systems, and that's something that we need to work on. Less speculation, more actualization. Okay. Ways forward, we're trying to do some of this work. I'm shamelessly plugging our group, NAIL, Nursing and Artificial Leadership Collaborative. So if you're interested, get in touch with our website. Also looking towards, am I like 1 minute? 1 minute. Okay. Looking beyond healthcare, looking beyond you know, the awesome work that's been being done elsewhere, that have looked at this for many years and have had more time to think about this. We're kind of in the clinical space, and that's our expertise. And then also pointing to a different way forward. So this is Abundant Intelligences movement. So this is an offshoot of Indigenous AI movement in Canada, where the Indigenous people themselves are taking ownership. So Indigenous people have never been at the table. They're building their own table. So can we look at these kinds of examples to move forward? Thank you. And this has been a goal to get my dog on the big screen. So.
Oh, there's my timer clicking now. You had 5 more seconds. Thank you very much, Dr. Ronquillo. Zarina, that's a hard act to follow. And thank you for your words. And I am very excited by the enthusiasm in the room in responding to your talk. I have now the privilege and the pleasure of introducing our second keynote speaker, Professor Zarina Lockmick-Tompkins. Zarina uses her expertise in environmental health and climate informatics to develop innovative approaches to climate solutions, aiming to mitigate the impact of climate change on global maternal and child health. Join me in welcoming Dr. Zarina Lockmick-Tompkins to the podium. Thank you. I'll sit down there and I'll give you 5-minute warning.
I have to admit that when I decided to go into climate change research, I consciously decided not to follow anybody's path but my own. And, how do you put an issue such as climate change into 20 minutes? But let's see how we go. What I would really like to do today is not so much talk about what I've done and how I've done it, but rather inspire all of you to walk away today thinking that you too can do your best to make a difference. And in this conference, we spoke a lot about how we need to create sustainable pathway for younger generations to become nurse informaticians and to lead our profession into the future. And today, I would like to tell you all that it's still our responsibility to tackle climate change issues today, because that is our responsibility today, and not to leave it for the future generations to tackle. Because fundamentally, each and every one of us right now has tools in their box to make a difference. And in some ways you already do through reduce, reuse, recycle at home. But there is so much more we can do. I'm going to start here by introducing you to my favorite patient. It's planet Earth, or as my people call it, Gaia. And Gaia is about 4.5 billion years old, and it has supported life for about 3.8 billion years. And it has now about 8 billion people on the planet. Gaia is facing 3 existential planetary crises. One is climate change, but the other is pollution. And the next one is the biodiversity loss, so the loss of animals and plants, microbes, and all the things that we know as they are existing today. All these changes impact the air, the land, and the water, which are necessary for good health, not just for humans, but for animals, plants, and microbes too. And as these are influenced, and as they change over time, what we are finding out is that on 22nd of July this year, planet Earth has hit the warmest temperature that it ever has recorded in the history of Holocene, which is about 11,700 years old. And that means that we are entering, according to the planetary boundaries framework, into uncertain area. Because if we bypass the 1.5 degrees Celsius, which is predicted to be a stable temperature for the planet to exist as it is, we're actually entering into uncertain future because the climate models are not able to predict what that will actually really look for us. So it is necessary that while we continue the mitigation efforts, we actually think about adaptation. Adaptation today, tomorrow, and into the future. And if you're thinking about climate change impact as one of those main threats, when it's translated to the human health, so far the epidemiology studies actually tell us that it will impact pretty much every aspect of our physiology, but it will also impact mental health and well-being. It will impact our cultural practices and the way we are relational to one another. It will also impact how we are moving around the world, because as the planet becomes challenged, we will see water shortages, food security issues, and so on, meaning that there will be changes in how our world is distributed. And of course, if we are impacted by heat waves, floods, and droughts, intensity of which will actually increase as the climate changes, intensity, frequency, and duration, that means that there will be pressures on our healthcare systems to meet these demands and needs. And really, it doesn't really matter whether you believe in climate change or not. What actually matters is to think about how we make these resilient systems become more a reality sooner rather than later. And what that really means is to actually think about every single process that we do in our hospitals, in our healthcare settings around the globe. How do we support global health population? And really, how do we support the health of future generations that haven't even been born yet? World Health Organization has actually been working on this for quite some time. And because they understand that there will be a change in frequency, duration, and potential impact of these hazards on healthcare systems, they've actually developed a framework that can be implemented pretty much from there onwards. And what they've also done is to actually tell you how to go about implementing that framework. I think what's really important at this point to recognize is that climate change is not just natural disasters. And this is not all just about disaster nursing. It is actually ongoing change in terms of what's happening with our temperatures, what's happening with our air, what's happening with the geological systems in terms of carbon cycles and so on. And healthcare itself has to look really deeply into what it is doing to nature. So we know that about 4% of global emissions are coming down to healthcare, the way we run processes, the transport that is engaged, for example, in supplies, procurement, and so on. And we have to rethink carefully every model that we have in our healthcare systems of how to actually reduce the carbon footprint associated with what we already do. But we also have the responsibility of caring for the health of populations. So how do we actually do that? How do we meet the increased volume of care that might be required? How do we educate the populations to protect their health? How do we help people adapt to a much hotter future? And as I mentioned earlier, there is this real tangible uncertainty that exists. If we hit over 1.5 degrees Celsius, which we probably will by the end of this century, unless things change dramatically by 2030. And really, what does this mean from birth to death? What does it mean for a newborn, for someone who is middle-aged and someone who's actually older? What does it mean from social determinants of health? What does it mean from environmental determinants of health, which, by the way, we hardly ever mention when we talk about care and healthcare and protecting health? That has to shift in our way of conversations with patients, in our conversations with policymakers, with anyone else who comes in contact with us in order to make changes in how we deliver care of the future. So really, what do you as the guardians can do to protect both planetary health, human health, animal health? Where does this actually go so that the future generations don't end up with a massive problem that cannot be solved? And you would have heard a lot about mitigation and the need to stop fossil fuels in terms of being extracted from the Mother Earth, from being burnt and from being used. And that transition to renewable energies will take time. And there will be a transition period where there will be a use of fossil fuels to enable that to happen. But what to do in the meantime? I refuse to cry. I refuse to give up. I refuse to recognize that this problem is so big that it cannot be solved. Occasionally, I feel really discouraged by what I sometimes see. But most of all, if I cry off 5 minutes, I'll get up, I'll move on, and I'll just keep going. And I think it's important that we all do that from today onwards at any given time. You start by educating yourself. When I entered this field 3 years ago after the Australian 2019-2020 bushfires, which had a devastating effect on us as a country and a community and a family, you start off by saying, what do I need to know? Where do I start? How do I use what I have and what I know to make a difference and to make the adaptation possible? Because that disaster is not the last time that this has happened. But in Australian settings, at least, it's the first time that the climate change has been acknowledged as the driver of what happened that summer. So when you educate yourself, recognize what your limitations are, but recognize that you're already experts in nursing informatics, in anything else that you do. And while indeed you can make individual choices in how you run your household and how you run your life, there is so much more you can do in terms of advocacy. So here, for example, we can talk about what happens with all the digital health technologies that are being used. Where do they go? What happens in terms of their recycling? Unfortunately, a lot of our e-waste is taken to the developing countries where the actual recycling processes are not always regulated. And more importantly, people don't have the ability to process them the way it would have been done here. And that means that a lot of times people burn plastic rubbish to try and get copper wires in order to put food on the table for people. And we've heard quite a lot about equity and why this is actually so important, not just in AI, but in every aspect of the life that we do. So this is something that we can advocate for. And when I say advocate, I don't mean stop the export there, but rather support those countries to implement processes that can actually enable those people to have jobs and feed their families still. We have that responsibility. As nurses, as midwives, as healthcare professionals in general, we have the responsibility to engage because we will be caring for those people when they come to the hospitals or when they meet them, or when they meet them in the community. We actually can go and attend COP meetings or any other big meetings. We need to be at the table, as mentioned earlier, And we need to advocate, advocate, advocate. It is the pillar of nursing profession to advocate for the patient. Here, the difference is that in addition to advocating for your patient, you're advocating for the planet as well, and for the future generations. How do you apply nursing informatics? Where do you start? Where do you go? In our case, when we first started this journey, the question always came back to either digital equity, how do we make that possible in new digital models of care, or it came down to, well, is the data that is being collected biased? Can we standardize it? And what we really discovered very early on is that our data doesn't have environmental determinants of health in any of our records. So one of the things we did do is to actually map out the United Nations Disaster Risk Reduction Hazard Information Profiles, of which there is 302, to SNOMED CT, because we thought that that would be the best way to start to change things, to change conversations. And about 90% of our recommendations were indeed implemented by SNOMED CT, meaning that in 90 countries, we'll be able to actually start to document differently the encounter with the patient and what the environmental component of that health might be. But what does that mean for you? That's where we started, but what is it that you can do? Every single process in the hospital, whether it's to do with finances, administration, nursing management, delivery of care, any aspect in terms of what's happening in a community at the bedside, can be reviewed in terms of what it does to pollute the environment, what it does in terms of carbon footprint. Every process can be reviewed, and actually we can review how we use single-use items. How do we actually ensure patient transport? Could we actually develop digital models of care that are also carbon sustainable? One of my pet peeves is when people talk about telehealth as being, environmentally sustainable. Well, it's only environmentally sustainable if the equipment that you use has lower number of pixelations, has less energy requirements, and it's less complex. The more scrolling bars you have, the greater the carbon footprint. The higher pixelation of your screen, greater the carbon footprint. So it's actually how you frame what is carbon sustainable that actually makes a difference in the end. So if we are looking at something being carbon sustainable, not, in other words, reduce carbon footprint, we really need to be honest about what that means so that we can evaluate these systems to know that they are indeed doing what they need to do. But also, if you're thinking about rural and regional and remote patients, they actually really need that telehealth to access care, because in many of those settings, in Australia at least, there are no healthcare services. That's their best access here. So what do we do to make that better? That could be one way of doing it. But the second thing also, during heat waves, for example, you can design your electronic medical systems, or EHRs, or health records, whatever you want to call them, to actually review the patient lists and identify who is vulnerable to heat waves and see whether the appointment can be rescheduled so that they don't have to travel from a far distance to where they need to be, and actually either use telehealth, for example, or alternatively reschedule that appointment for when it's safe. So there's lots of things we can do in how we run our practice to be able to actually make these models more sustainable. We can also improve the resilience of our workforce. So at the moment, we launched a study 2 days ago, very cheeky of me, I know. But COVID-19 was a huge impact on our workforce. And I don't know how many of you know, but COVID-19 is actually linked to be a zoonotic disease. And as the climate changes and the geographical temperatures shift, and we actually erode the environment through deforestation, we will see more of these zoonotic diseases occurring. So it's not that we know we might have a pandemic 100 years down the track. We'll probably have it a lot sooner. And really, I don't know about you, but when I reflect on COVID-19 impacts on our healthcare workforce, it feels like we learned nothing. Like our health systems have just continued like it never happened. We can't let that happen. We have to build on the lessons learned. And we have to create something that will actually give us resilience so that we don't have mass exodus of nurses when things calm down and when the World Health Organization declared that the pandemic is over, but we know at the bedside that it's actually there. In Australia alone, 75,000 nurses left the nursing profession since the COVID. That's a huge number when you think about that. In 2023, we had 423,000 nurses to serve the whole population. So in this study, we actually want to try and develop a framework to see what that might look like in terms of building that resilience. What do we need to do to empower the individual and organizations, policymakers, to see what new ways of working and doing we need to do in order to make that happen? So if you have a spare minute and you think that you can contribute, please do so, because this is also creating a resilient workforce to meet the demands of the climate that is coming. Perhaps where I really will challenge you is how you think about care. Forever, foundations of delivering healthcare has been person-centered. Do all you can for that person. Use whatever you have to do what you need to do. And that often means opening a pack to, for example, change a wound and find that at least in that pack there will be 3 or 4 items you will never use. Where does that go? Landfill. So when you're thinking about models of care, I'm not asking you to stop thinking about the person. I'm asking you to think about the planet. I'm asking you to talk to your suppliers and review what those packets look like, whether that can be remodeled so you don't actually need to use all of them. I'm asking you to think about what happens on admission, what happens when you actually assess a patient, what happens when you develop your care plan. I want you to think about what happens when you send that person home. And in particular, on that discharge point, what are they going home to? During heat wave, maybe a region that might be prone to floods, hazards. Who do you need to connect them with so they can go to a home that if it's not air conditioned, there is another strategy to support them so that they don't actually come back to you within a couple of hours or a day or so that they are safe when they go home. So think about these environmental determinants of health when you admit a person and you prepare that plan and when you send them home. Thinking about planet is a really interesting thing. In some way, you live in your own universe. And if you think about that picture I posted at the front, there's this huge planet. And if you think about your size relative to that planet, you can't really see yourself. And yet here we are, connected to it. Connected to nature, connected to the air that we breathe, the water that we drink, the land upon which we walk. And perhaps the challenge for you will be is, if you're not connected to nature, to find a way to reconnect. We've heard a lot about nature prescribing as being one of the ways of actually alleviating the anxiety, particularly in younger people, regarding climate futures. But we've also seen about nature prescribing as a way to manage mental health and anxiety, regardless of whether there's a climate impact or not. Becoming more aware of how we actually bring environment back into nursing, and it was in nursing in 1800s when Florence Nightingale was around. Bringing that back in and making it part of the care that we deliver will actually make a huge difference too, because you're also educating the patient who you actually want to go home to be able to change their own ways of managing care and what they have. Find your tribe if you're on your own, if you want to go on your journey, and this is my tribe. When I feel that things are not quite going the way I like them to go, I turn to my tribe. Sometimes it's about just having a banter and going, but actually more importantly, we think together as a brain tank and we develop solutions. And without these people, I would not be here talking to you today. So you're not alone if you want to start. If there's no one around you who wants to be part of it, come to my team. There's empty spaces here to fill. Even if it's just a conversation that you want to have, our doors are open to you. But perhaps the more important thing is to find your why. I can tell you my life's journey and why you should be here, but really, it has to be you who drives this. When you go home today, think about what is your why, and I will show you today what is mine. Thank you.
lots of things to think about. The speakers will be around at the end. If you have any questions for them, you can ask them specifically, but thank you. No questions. Charlene says no questions. All right. Okay, now I'd like to introduce Max Topaz, who and Glinda Reese, who are the planning committee for student awards, and they are now. Oops, there you were a bit earlier. There's my timer. This is Max is the co-chair of the IMEA NI Education Advisory Panel. Glinda is a member of our scientific program committee for the conference, and they will now present the Best Paper Awards for the student papers and posters and case studies. I'll pass it over to you, and you can, there we go, there's your slides, and there's the...
All right, there's a big button that says next here. All right, great to see that everybody is sticking up to this moment. That's very exciting for us. We worked really hard on trying to identify those finalists and then try to judge those finalists' works and then come up with the list of the final awardees, which we have done successfully. All right, let's take a look at what's up. So these are the Best Poster Award nominees. I would ask those folks to stand up, just so people can see them. Yeah, please. All right. They don't know anything about that, just so you know. All right. All right, thank you. You can see it now, and then in the next 3 slides, we're gonna look at the winners in this category. So this is posters. All right, let's take a look at the 3rd place. Ooh. All right, let's go to the 2nd place. And can this person stand up as well as we go through those? Say it again. Can this person stand up as well as we go through those? All right, yeah, thank you. Awesome. All right. And the 1st place goes to von Gerich Hanna. Please stand up. You have to stand up. All right. These are our winners. All right, let's switch to the best papers, and I'll let Glinda do the job.
Thank you. Okay, so our best paper award nominees, if you could also stand as well for the 5 papers. Lukita Sari, Ori Black, Lee. Is Lee here?
No, I don't think so.
Von Gerich, okay, congratulations. And Alcaran, is Yasser Alcaran? No, not yet. Okay, and then moving on to the 3rd place. Von Gerich, congratulations.
All right.
2nd place, Yasser Alcaran. And 1st place, Dr.
All right. And it goes without saying that the competition was really tough. They were great contenders in those categories, and it's hard to judge. But those are some of the highlights, and those are the winners. So I hope you enjoyed that. All right.
Okay, so we're on the final straight now. So can I just introduce Anne Kristin, the chair of IMEA and I, who's got a few closing remarks to make.
I have one word, and that is, and that is, oh my God, what a good ending of such a good Congress as we have had. I'm so touched. That's not because of my voice now, but I thought that yesterday evening was going to be the top of the pops, with the dancing and dining in a totally different way than we have had before, but this session has been my top of the pops. I have to say, when I'm standing here, I have to give a great gratitude, acknowledging both the local committee, the editorial committee, the scientific committee for this wonderful program that we had. I've been speaking with a lot of you throughout these days, and everyone says this has really been a different conference or congress in a good way. And I think that difference is also part of development, which we are working with. So I think we are doing very good. So, for those of you who didn't, oopsie, next. Doesn't work. Can you help me please with the slides back there? Maybe I should try back. It is well, like it started. Whoa! Oh, that was very much. This is where I wanted. Yeah. For those of you who didn't hear this yesterday, we have a leadership award that we provide every time we have a congress based on engagement in nursing informatics, for nursing informatics. And this time was the time for Diane Skiba. She has been a long-standing teacher and educator and developer within nursing informatics. A big applause to Diane. She's not here, but anyway. And this has nothing to do with EMEA and I, but as you can see here, the American Medical Informatics Association Nursing Informatics Group selected students to be awarded on the fund in honor of Dr. Virginia Saba. The fund were donated by the family, friends, and colleagues. And the selection committee includes Dr. Susan Backen, Dr. Constance Berner, Ms. Marina Douglas, and Dr. Kathleen McCormick, and Dr. Susan Newbold. And the winner of the prize, Dr. Ursula Snigerska from the University of Florida. Are you here? You want to stand up? And Mrs. Yuna Wang, are you here as well? Yeah, there you are. From Pittsburgh. And you won a highly competitive award. So I hope you have enjoyed this Congress, and congratulations. Then we are getting near. So this is the time for the board that has been running EMEA and I the last 4 years. We still have some tasks to do the rest of the year, but anyway. This is my team. This is the team of the board. Joy Lee, are you in the audience? There you are. Joy Lee from Taiwan. Margie Kennedy from Canada. Michelle Honey, New Zealand. And Nick Hardiker from UK. This has been a dream team. We have been working so well together and had so much good times online continuously. This is the first time we met at this Congress since the beginning, and a little bit of COVID in between. But we managed it. We managed to keep EMEA and I going through those hard years and give new energy into the group, I would say. And with that, thank you. And with that, I will hand over, and I would like to invite you, Nick Hardiker, to the stage, to the new board of EMEA and I. couldn't be better than hand over the baton to you here in Manchester, your home city. Nick will be the next chair, and alongside he has Joy Lee, who you saw. She is the continuity together with Nick. Hi, John. And we have Dawn Dowding. We have Helen Allman. And we have Ulla-Marie Kinnunen. Ulla-Marie, are you here? She left. So this is the new board, and I would say good luck, and I'm looking forward to the next steps. You need a bit of luck, but with all that knowledge in on one plate, I'm sure that we will get a bright future in nursing informatics within INI. Yeah, so if you have any questions, you want to join, you want to engage, these are the persons to speak with. Yeah. Do I have anything more?
You have one more slide after this. You're going to introduce Greg. One more slide.
I am introducing Greg before this. We want to switch. Greg, the US representative of EMEA and I. He will be the contact person for the next NI Congress.
Thanks. Next.
Hi, so I was asked to come and introduce the next Congress, and I'm Greg Alexander. I'm a professor at Columbia University in New York, and I worked with a team of people that helped me put the bid together. I'd like to recognize them real quick. Judy Murphy, if you don't mind to stand up, and Vicky Tiaze, if you don't mind to stand up, and Kenrick Cato, if you don't mind to stand up. Thank you so much. And these individuals were super helpful in getting this bid put together, along with my co-chair, Karen Dunn-Lopez, and I think Karen had to leave, so, I saw you wave, but you're not Karen. But she had to leave. So these are all the congresses that have happened in the past, and so we're going to have our 17th Congress in Las Vegas. And in Las Vegas. As I said, Karen Dunn-Lopez is my co-chair, so we'll be working together, hopefully with our team that helped us put this bid together to make the most of our next 4 years to bring you the best Congress ever in fabulous Las Vegas. Somebody said Viva Las Vegas and said voices of informatics, voices of something else, but I can't recall. I need to figure out who told me that, but it was kind of exciting. So Viva Las Vegas. It will happen from November 2nd to November 5th. Of 2028, and our location is Caesar's Palace in Las Vegas. Our theme will be pushing boundaries, digital in a nursing world. Like I said, Karen and I will be the co-chairs, so we'll be starting to put together a committee to help us. We will be meeting with the committees that put this Congress together to help debrief us on what to expect and to prepare for the future. Again, I want to recognize these people and the important role that they played. Jeff Williamson is a member of AMIA who also supported us. Is Jeff here? I didn't think Jeff was here either. But he was super supportive and will be helping us as AMIA and our team works together. Again, I wanted to show you a little bit about Caesar's Palace. It's a great place if you've ever been there. It's very large, and it has a lot of amenities that will make the Congress really excellent. One thing about this is that we are working with Caesar's Palace to provide this EMEA-NI conference in conjunction with the AMIA Fall Conference. So they may overlap just slightly, but a lot of people from EMEA-NI come to AMIA on an annual basis, and so this will allow people to stay on maybe a couple of extra days to attend a Congress that they normally come to at the same time. So hopefully we'll be able to synergize those efforts. And this is a little bit about Caesar's Palace that you can, will inform you. If you have questions, please reach out to us. And if you want to help us work on this, we'd be more than happy to have you be part of our team. Thank you for the opportunity.
Okay, thank you, Greg. So, this is now Leanne and I with our closing remarks. So, just to let you know, this is an updated slide with the total participation of the conference. We had a few people who arrived on the day. So, just again to show how many different countries have been represented at this conference, the full international representation of it across the world. And we would like to thank each and every one of you for coming and participating and joining in what I've heard have been stimulating, exciting, and just great conversations. And let's hope that some of the friendships that you've made at this conference carry on when we meet again in Las Vegas, if not before. So, just to reiterate, this conference couldn't have happened without all of the wonderful people who've participated in helping to organise it. Leanne and I you've seen quite a lot of us in the last 4 days, but actually behind the scenes, all of the people on this slide have been working tirelessly for the last 2 years to help us to get to this point. So if any of them are still in the room, could they please all stand up so we can thank them again one last time. Two more slides of the moderators and volunteers. Those of you will know that we put a shout out for volunteers to help moderate in all of our concurrent sessions. Can I just say a big thank you to everybody on this slide for stepping forward and volunteering. Like everything with this conference, we put a shout out for volunteers, we got inundated with responses. Everybody stepped up, stepped forward. It's been brilliant. So again, if any of you in the room are on this slide, could you please stand up so that we can say thank you?
And especially thank you to those who did multiple sessions. Many of the people up here did multiple sessions, so thank you for those who did multiple sessions.
We haven't quite finished yet. The other thing you may have noticed is that we had a whole group of students who also put themselves forward to help volunteer behind the scenes, directing people, helping out with the technology in the rooms, and just generally being around and about. So again, if any of our student volunteers are still in the room, could you please stand up so that we can say thank you to you as well. And we don't have a slide for it, but all of you hopefully will have seen the guys from CPI, who are our events management company that have worked with us very closely. So Emma, I don't know if she's at the back, she sometimes is, she might have disappeared, and Laura and all of the other team that have been on reception have been brilliant. And the other people that we really need to thank have really been behind the scenes. So there's somebody called Bethany, who is the events manager here at the University of Manchester, and all of the media services team, the catering teams, the people who've served you your coffee, they've all done it with a smile. They've been delightful and just so helpful with some of the things and requests that we've had to ask them at the last minute. So could we please just thank everybody who's helped to make this happen. You will be, in your email very shortly, getting a survey to help us evaluate the event. and to make sure that we can feed into the planning for the next time. It's really short. We made sure it was really short. I think it's 4 or 5 questions. If you fill it in and you give your name, you'll get a certificate of attendance for the conference, just as a little bribe to help you fill it out. And we would really, really appreciate any feedback, good and bad, so that we can help for planning for next time. So just look out for that. We also, of course, want to thank the sponsors. Behind the scenes, without their financial support, we couldn't have done some of the things. So could we say particular thanks to Elsevier, our principal partner? They've really supported us quite a lot. The British Computer Society, BCS is the home professional organisation for us nursing people here in the UK, and they've provided some very generous support. Also, some of our other partners here, VAR Healthcare and Edan, Baxter, Emory, Woodruff School of Nursing, Kinetic ID, Lucit and Tendable. I think you've all hopefully seen their stands downstairs. For those of you last night at the dance party, we need to say a particular thank you to Oracle Health, who sponsored that, and Smart Nurse ENR, who sponsored our Wi-Fi. Okay, and so, Leanne and I might be slightly biased, but we think this has been quite a good event. Leanne said spectacular.
Yeah, I wrote spectacular.
But I'm British, so it's always the understatement. We've been particularly excited to see so many new faces here and hear about exciting ideas and innovations from our growing nursing informatics community. A particular plug for the EMEA-NI advisory panels. Those of you who came to the lunchtime event yesterday, you've already heard about them. Those of you who maybe couldn't make it, have a look on the EMEA website, try and find the advisory panels bit if you can, and please sign up, because that's where the workhorse of EMEA-NI is going to happen for the future. And also from our student and emerging professionals groups in EMEA, many of whom are here in this room and are now definitely emerging, I would have said, given some of the talks that we've had. So, on behalf of EMEA-NI and Leanne and I, could I say thank you for coming. We hope you have a safe trip home, and we look forward to seeing some of you on the next conference SPC. Other committees for NI 2028, volunteer, although it's been a roller coaster, but it's been great. Thank you very much. And hopefully we'll see you in Las Vegas. Thank you all for coming.
Thank you, everyone. And with that, we will close the Congress 20 minutes early. So have a safe trip home all.